I'm going to introduce Dr. Penn and let's get started. Dr. Penn and I have been colleagues and friends for the better part of 20 years through our association with the ACCP and the National Commission on Correctional Healthcare. I've known of his speaking skills for a long time, and I was thrilled when he agreed to take on out of his busy schedule to take on this responsibility for the ACCP in being with us for a grand rounds. I'll say that it's important that everybody know that these talks are the property of the ACCP, the American College of Correctional Physicians, and no use of them can be made without our permission, and the permission that is of the board of directors. That said, Dr. Penn owns the slides, and if he wants to give you the slides, that's all good. This session is being recorded, and the recordings are now available online to watch after the fact. I've had at least one person already be in touch with me and ask about looking at the recording after the fact, and that's certainly available. I have not looked at the link myself, but I will tonight. And the bottom line is that it may take 2 or 3 days for the link to post. But if you're happy with the talk, please tell your colleagues and instruct them on how to get online to see them. And it's on our website, the ACCP website. I think I'm very open to everybody's ideas about how these should be conducted, how to increase attendance, how which topics I'm missing from the agenda, that because we are trying to formulate a core curriculum for correctional medicine that we will have available to everybody online, and free for members with CME attached, even for the remote, even for after the fact, for looking at the recordings. There's CME attached to those. The ACCP has gotten that permission through the credits through the American Academy of Family Physicians, but we are only issuing credits every quarterly, so that it's not as much of a burden on our executive people who have enough on their hands already. Dr. Penn is the Director of Mental Health Services for UTMB. He's a full professor. He's an all-around great guy. He's a generous with his knowledge and expertise, and he's one of the better speakers that I've ever witnessed. And it was my great pleasure when he agreed to do this for us. So I will introduce him, and if you want to say anything more about yourself than what I just did, Joseph, please go on ahead and do, and don't be afraid to toot your own horn, brother.
No, not at all. Thank you, Mike. And it's a pleasure and honor to be here. Thank you all. I know y'all have busy lives. You have family, you have responsibilities, you have dogs, you have a lot of stuff. So thank y'all for being here. I have a lot of slides, and I'm going to kind of zip through some of this stuff pretty quickly. But if anyone wants copies, I'm happy to share these slides. So the other thing is, I know we have a lot of medical folks. And when I say medical, I'm talking about like primary internal medicine or other specialists. And so I may gloss over or miss some things. And so if I miss a disease state that you think I should include, I'm happy to, again, it's a work in progress. So I want to kick it off. The take home point here is what I hope you all get tonight is not everything that people are acting out or being problematic or disruptive is psych in nature, that we need to think about medical etiologies too and rule out medical. And so I'm going to be talking hardcore about delirium on dementia, head injuries, intoxication states, and other things. So that's kind of the main thing, is what presents as psych, but as medical and etiology.
I'll just jump in here and say that there's going to be plenty of time at the end for questions. Please put your questions in the chat area and save interruptions if you're able. If you have something really important to say, raise your hand and we'll recognize you eventually.
Thank you. And it's great to be here again. Thanks to the ACCP for making this possible. I posted something on LinkedIn, give you a little bit of publicity and press. Thanks to Mike. You're awesome, Mike. Mike and I share roots from Rhode Island. I'm a native Texan, but I lived in Rhode Island 15 years. And so we kind of share, forget about it, in other Rhode Island sort of terms.
Forget about it.
Forget about it.
Wicked awesome.
You're wicked awesome. Wicked awesome. Okay. So here are my disclosures. I'm a full-time state of Texas employee. My opinions are mine and not the state of Texas. I'm on the board for NCCHC, but I don't get any compensation. I don't own any stock. I don't own any COVID vaccine or anything like that. And then I do expert work on the side. So that's my part-time thing. Just to give you all the sense, in Texas, everything is bigger in Texas. My job encompasses about 80% of the state of Texas and 100% of the juveniles within our state juvenile correctional system. But pre-COVID, we were the largest state prison system, and I think we continue to be after COVID. Our biggest challenges are recruitment and retention of staff, both custody staff and healthcare staff, and mitigating suicide risk, self-harm, and obviously an aging and more sick, medically and mentally ill sick population. So those are our biggest challenges, providing access to care to the underserved in very rural, remote areas. And the point of this is not every little hospital in Podunk, Texas has a level 1 trauma center that has an MRI and, immediate access to imaging and blood work. So we're really looking at stuff like point of care testing and other things that y'all do a lot. So here are my goals, is to talk a little bit about the difference between kind of organic and functional conditions, and then obviously acute and chronic conditions that can be misdiagnosed as being psychiatric or behavioral in etiology. And then talk a little bit about some timely strategies to reduce morbidity and mortality, and I would add liability and lawsuits, because that's typically what happens when there's a bad outcome. So here's a good example of a patient presenting, an incarcerated individual, is brought into the medical clinic, altered mental status, angry, yelling, screaming, confused, mumbling, internally preoccupied. He's combative. As y'all know, in our settings, often they get tear gas or pepper spray or other physical hands-on sort of interventions, uses of force and such. Despite all the above, he continues to be verbally abusive and answers questions inappropriately, if at all. So the take home is, what does medical typically do? And I'm not bashing medical, but medical typically is like, oh, he's acting bad, he must be mental health, must be psych, right? And so anytime someone's aggressive, agitated, yelling, screaming, the patient's communicating a need. And so we need to really kind of do a root cause analysis and figure out what's going on with this patient. And obviously, our patient population may not be the most forthcoming, and they're often very challenging. How many, I'm curious, this is something that kind of has come out a long time ago, but there was a thought before that things were organic and there was a clear, neurochemical or physical manifestation, such like a brain tumor. You can look at it on a image. Whereas psychiatric issues like schizophrenia, bipolar, other serious mental illnesses, and even depression were sought to be more functional, that there was some there was not an organic cause, but it was more of an environmental cause. And we've come a long way in the DSM, and I'm not here to defend the DSM, but I'm happy to answer any questions. The DSM is a work in progress. And I think the biggest challenge is it's only been around since like the 1950s. And in my limited career, like in med school, it was DSM 3R, and we've gone from 3R to 4 to 4 TR to 5, and now 5 text revision. And so it's a work in progress. And I think the biggest challenge with DSM, in my opinion, is it's really hard to compartmentalize human behavior and think about it like diagnostic cubby holes. And I saw Michelle Staples Horn in the meeting. I think it's even more challenging with kids and adolescents, because developmentally, it may just be a stage or a breakup with a girlfriend or oppositionality or defiance or some age appropriate interaction. And kids can get pegged as being bipolar or ADHD or what have you. So the point I'm trying to make is DSM is a work in progress. it's very cross-sectional and it's not longitudinal. And to do a really good assessment, you really need longitudinal data and information as opposed to just a cross-sectional, like a Polaroid snapshot here and now. You want to really look long term. And this is Joe Penn's opinion. I think DSM, by going away from the axes, was a mistake. I find the multi-axial, axis 1 through 5, to be very useful. And you can have somebody that has hypothyroidism, has histrionic features or antisocial personality traits or borderline traits or what have you. And, oh, by the way, they also have hypothyroidism, and that hypothyroidism manifests itself with depression or fatigue. And so the point here being that previous DSMs, up until DSM 5, I believe, it was pretty much this multi-axial, and now they moved away from that. So anyways, I just wanted to share that, and I don't want to put everyone to sleep because diagnostic nomenclature is really tedious at best. But the problem is DSM and ICD, there's some overlap, but there's a lot of differences too, the International Classification of Diseases. So let's I think that's enough nosology and diagnostic terminology. And let's really focus on what you guys are here for and women are here for today, which is, what do I do about a patient who's causing problems? So if y'all get nothing else from me today, I think delirium is probably one of the most commonly missed and things that people miss. And it's been around. If you look in literature, Charles Dickens, back in the Pickwick Papers, my dad was a huge Dickens fan and he read all this stuff, but it's actually written in great detail what delirium presents. And another problem with delirium is there's so many different terms. So if you talk to a neurologist, I had a neurology attending in residency who was from South Africa, and he talked about a toxic metabolic encephalopathy. And so, in psychiatry, we call it delirium or acute confusional state. But there's different terms: ICU syndrome, ICU psychosis, and then some people get confused a little bit with delirium tremens. So I'm going to try, if there's time, to say a little bit about that. But the point being, delirium is delirium is delirium, and you got to work it up and you got to manage it and you got to treat it, because if you don't, and let's say they're septic, they're they're natremic, whatever's going on, if you don't address the delirium, they can die or they can have significant morbidity and mortality. So the big take-home point is an alteration in their level of alertness. They can be lucid and attentive and have good memory in one minute, and then 5 minutes later, they think they're on the moon. They think that they're in church, or they're getting, they're going to communion. I mean, so it can be very. The take-home is it's fluctuating, and it happens a lot in our medically compromised patients, especially patients in nursing homes or assisted living, and in our situations, infirmary-bound patients or patients in skilled or convalescent care sort of things. And the problem is medical and psychiatry kind of point the finger at each other, and no one takes ownership over the workup and management of these patients. So the big take-home point is that it's waxing and waning. And so you can have someone, say a 70, 80-year-old man, for example, or in our situation, 50 or 60, and y'all know in prison, people add 10 years to that. So a 50-year-old really has the body of a 60-year-old. That's kind of how I think of it. But the bottom line, the beauty of delirium is it's reversible. If you can figure out, say they're septic, they have a UTI, they have pneumonia, there's some infection, and I'm going to give you all a really nice mnemonic. That's one of the few mnemonics that stuck with me over 20, 30 years of doing psychiatry. But the beauty is it's reversible. Whereas unfortunately to date, dementia is not reversible. So that's a really important, waxing and waning. And typically it's an acute onset. So it's very rare to have someone who has chronic delirium. It kind of comes and goes. And again, waxing and waning, that's a big take-home point. So in our patients, obviously you want to think about different etiologies, but one thing that kind of stuck with me from doing internal medicine during my internship year was hypoxia. You got to rule out hypoxia. If they're not getting enough blood to the brain, they can get confused. If they're hypoglycemic, their blood sugar is too low or too high, say they're in diabetic ketoacidosis. There's so many different things. And a lot of the medicines that we use, both in surgery or post-surgery, or even for pain, and I'm going to get to psych meds at the end because we have some culprits for things that can cause people to have changes in their mental status. But all of these are some things, and obviously this is really hard to remember, but I'm going to show you all a quick mnemonic that I find really useful. So again, I think the clinical pearl is purposeless behavior. So you may find somebody picking at their skin, picking at their hair, just grabbing in the air, there's no real clear reason why they're doing that. It's purposeless behavior. So that's an important take home point. The other thing is often they can have hallucinations. Y'all know that patients with schizophrenia may have auditory or visual hallucinations, typically auditory much more common. So if someone's having visual hallucinations, like they're seeing things, that's much more suggestive of delirium. You really want to think and work that up. Or tactile, if they have formication, the sense of ants or insects on their body. Another thing, delirium, and you might see this with a patient, say with Parkinson's disease, who is on too high of a dose of a dopamine agent, they might misinterpret, like they might see a chair as a monster, or they might see you coming in and think you're a dragon, or, so they misperceive the environment or misperceive things. So again, the big thing is if you don't diagnose and treat it and manage it, they end up going to stupor, coma, seizures, and death. So that's the bad outcome of delirium. And I will say, I'm going to throw on kind of the correctional realm. We see the risk, especially in jails, county jails. You might see benzo withdrawal resulting in delirium. So I would say that's a big take-home point. If someone's doing a lot of Xanax, a short-acting benzo, Xanax, Ativan, and they come into your county jail or your prison, hopefully they've been detoxed if they come to prison while they were in jail, in county jail. But if they come to you in county jail, you've got to think about withdrawal delirium. So that's something to think about. And alcohol, obviously, we'll talk about that. Let me just move on in the interest of time. I think the big take homes are schizophrenia and bipolar are long-term. You could have a patient that has schizophrenia, develop pneumonia or something else, or sepsis, or hyponatremia, and we'll talk about psychogenic polydipsia in a second. But typically, it's long-standing, whereas again, delirium is waxing and waning on and off. And obviously, and dementia is kind of a chronic, insidious, higher functioning, and now they're forgetting things, they're having word-finding difficulties, they get lost. And then, so it's different from that acute onset. It's much more of a slow and gradual process. And here's some data, very common, as y'all can imagine, terminally ill. Before, when we had AIDS and the AIDS epidemic back in the 80s, 70s and 80s, you'd see a lot more of that with the PCP, the pneumocystis carinii pneumonia, and things like that. You obviously see it in a lot of patients that are elderly and cancer undergoing chemo and other treatments. And then obviously anyone that's hospitalized, you need to think about it. So if y'all get nothing else from me today, this is one of the best mnemonics I've ever found. And it's I watch death. I for infection, could be fever, CNS, it could be meningitis, encephalitis, UTI, urinary tract infection, pneumonia, sepsis, withdrawal. Wernicke might progress to Korsakoff's. We can talk about that if y'all are curious. B12 and folate deficiencies from drinking a lot or being, alcohol dependent. Anoxia. What I was going to throw out about toxins, y'all need to think about your trustees, the people that work out in the camps, that work out where they're dealing with like chemicals or garden, if they're working with insecticide or pesticides or any kind of field chemicals. Need to think about heavy metals, that sort of thing. There's a little bit of overlap, sorry about that, about CNS infection, seizures, meningitis, encephalitis, hemorrhage, subacute, or subdural or epidural bleeds, hypovolemia, y'all know this, natremia, hyponatremia, or alternatively somebody who is volume overloaded. We see a lot of this with in our system, we see a lot with our folks that are undergoing dialysis. So you see these rapid shifts in their potassium and their sodium and what have you. And then obviously drug withdrawal. I'm going to talk a little bit more about K2 and spice and some of those other fun things that we're experiencing specifically in Texas. But if y'all get nothing else from me today, what do we see a lot of in our system? We see a lot of hepatitis B and C resulting in liver damage, right? And when they get the liver scarring, then their ammonia builds up because they can't clear their liver. So one of the seminal things that we deal with in our system is medical will say, this guy's acting confused or this, whatever. And first question we say is, what's his ammonia level? And so really wanting to rule out or work up to make sure that they're not developing an hepatic induced ammonia toxicity from that. And then alcohol withdrawal, we'll talk about that in a second. Tumor, head trauma, I'm going to give you all some examples of that. And then lastly, any kind of hallucinogens, intoxicant, medications of abuse and that sort of thing. So I hope you all find that mnemonic useful. Again, it's hard to remember it, but it's something that just kind of think about that in your differential. Like, why is someone acting strange or odd? Don't just go to bipolar and schizophrenia. Think about all these different medical etiologies that can cause change in mental status, specifically delirium. So delirium tremens gets thrown out a lot. Fortunately, we don't see it a lot. I'd be very curious, and we can talk about this at the end. How many of y'all have actually seen a recent case of DTs? I think we've come a long way with managing, like using Librium chlordiazepoxide and managing folks that are in alcohol withdrawal. So that's the good news. But the bad news is when someone is not picked up, it's a very severe form and it's life-threatening, and it can progress to cardiovascular collapse. They probably would need an ICU. They probably need ventilator and all that fun stuff. But they can really develop, it can progress very quickly. And here are some of the other things, just to think about. The big things are sensitivity to light. They can alternate stupor, excitement, hallucinations. I think I talked earlier about formication, about bugs crawling. So these are some of the things you'll see with a patient who's going through delirium tremens. Again, very rare, not that common, but something really life-threatening and something to think about. So I thought I'd just give you all another example. A patient with a chronic mental illness, serious mental illness, has schizophrenia. Again, the DSM has changed it now. Now it's not chronic paranoid, it's schizophrenia with chronic paranoid features. Don't ask me why they did that, but they did. So anyways, the patient has HIV, hypertension, hep C, and cirrhosis, and is brought in by custody because he's urinating on the floor and defecating in a trash can. He says the cops are trying to kill him. And what happens? Custody's like, come on, doc, hurry up so we can clear him, so we can move him. So again, we need to work collaboratively and collegially with custody because they're our partner. But basically, he's only oriented a person. So that right there makes you think, okay, there's something wrong with his attention, his orientation. He refused vitals. That never happens, right? Every patient we have is compliant and cooperative unless you do what you want. I'm kidding. But this is the problem, is that how do you do an evaluation if you can't even get a set of vitals on someone? So finally, they're able to get the vitals, and a little low blood pressure, his tachycardia, respiratory rate is up. O2 sats are only 90%. He's confused, intermittently cooperative. Again, difficult exam, but nothing specific. And then he quit going to the pill window. That's kind of the history you have. So these are some things to think about. The low oxygen, maybe hypoxia. You try to give him some oxygen there, but he won't leave it on. Also common hypoglycemia, maybe because of the cirrhosis. Alternatively, his blood sugar is actually pretty high, 156. So other things to think about. Could he be a GI bleeder? Could he have varices? Could there be something else and he's anemic? Again, very common for patients comorbid with, and y'all probably manage many more of these than I ever have. But an occult bleed is another thing to think about. Any kind of metabolic abnormalities, hepatic encephalopathy, electrolyte abnormalities, hypothyroidism. And I'm kidding y'all, but y'all know that many of your units don't have immediate access to blood work, labs, and testing. And so that's one of our challenges in Texas is we're working on point of care testing, and we're working on partnerships with local emergency rooms and labs and all that, but it's a work in progress. It's really hard, especially if you need more specialized lab testing. So I think utilizing telemedicine and having a set partnership or collaboration with local emergency rooms is instrumental. And obviously when you have a pandemic like COVID, the ERs don't want our patients. So that's another challenge is they're like, get them out of my ER. We had a situation in Palestine, Texas. Yes, there's a Palestine, Texas. I've been there many times. But anyway, so we had an outbreak of COVID at one of our prisons, and we tried to take some patients that were unstable to the local emergency room. Lo and behold, a local nursing home was experiencing the same thing. And so obviously then you kind of get into the economies of scale, who gets priority in the emergency room, in the community hospital, the prisoners or the nursing home. So these are some of the challenges that we get to deal with, and judges yelling at you and get your inmates out of here, manage them, take care of them somewhere else. So obviously our patient population has challenges and there's stigma. Okay, off my soapbox, back to the content. So other things to kind of think about, CNS lesions, infections, and then what to work up. And you guys know, I mean, I'm not going to tell you what to do, but obviously you want to do some kind of medical workup. And I guess in my experience, one of the challenges I've had, I don't want to bash emergency room doctors, but we have had some experiences where if there's a mental health issue, we have challenges getting a really good workup and also getting the labs or studies of what was done back to our unit. So those are some of our real world challenges that we deal with. They say that they're medically cleared, and then they send them back to your unit and they're not much better than they were when you sent them off. And then you're like, well, what did they do? And then you get this patient safety. You have a headache, take this, don't do that. It's like, that doesn't help me because I don't know what kind of workup you did. So I think being able to get labs and results and be even better, being able to talk directly to your ER folks is really, that's key if and when possible. Two other labs to work up and think about, LFTs, BUN creatinine, thyroid, UA. I think a UA is very safe and quick and easy. It's a relatively easy thing to check. And then looking at other things, obviously blood cultures takes a while to get the results back, but other things, and again, I apologize, it's kind of a laundry list of different things to think about, but just use your clinical judgment. What's hunting deer versus what's hunting zebras? And I think you want to kind of just get a real basic, metabolic profile and figure out what's going on. And if you're still scratching your head, send them out and send them to the local emergency room and let them work them up. I think you're better off safe, and it's a good defense. And I'm not telling you to send everyone off site, but if in doubt, you've done a good workup on site and you still don't know what's going on and they're still acting strange or odd, I think it's fair to send them off site. So other things to do, obviously, I know all of y'all have MRI machines and CAT scan machines on site, right, at all of your facilities. I'm kidding. I know it's very hard to have that. Maybe you might be able to get an EKG or pulse ox and that sort of thing, maybe even mobile imaging, chest x-ray, what have you. Obviously, I'm not advocating for lumbar puncture, but I would consider, if you really think that there's something going on, meningitis, encephalitis, or something else, you could do an LP or you could send them out for that. And last, EEGs. So this is more of a board exam question than, I don't know how many of y'all routinely order EEGs. I would say unless you're a neurologist or you're thinking, medical workup for seizures or change in mental status, I would say probably neurology is the one probably ordering most EEGs and not medical or psychiatry. So I'm a big visual person, and I think this is, if y'all, again, get nothing else from me today, our population is just growing and aging, and we're getting, everyone has comorbidity. It's not they have one disease. No. Now they have schizophrenia and hepatitis B or C. And oh, by the way, they also have, cardiac disease and insulin-dependent diabetes, and they're in pre-CKD, chronic kidney disease. So those are some of the biggest challenges of managing kind of the silver tsunami that we're experiencing nationally. And this is an older slide. I don't know if it's current. It may be a little outdated, but we have a huge chunk of inmates, both male and female, that are aging, and a growing transgender population too that's aging also. So dementia could be a separate talk in and of itself, but I just want to give you all a heads up that, I think we've come a long way. Before it used to be like, is it Alzheimer's or not Alzheimer's? Is it multi-infarct or not? Vascular dementia, Binswanger's or not? And I think we've come a long way. There's still obviously a lot of subtle findings, but these are some of the things that you can do, like show me how you'd comb your hair, show me how you'd brush your teeth. Where are you? What's the name of this place? What's the date? What's the month? What's the year? Being able to figure out, could they have aphasia if they're having expressive language difficulties, or if they're having trouble like carrying out motor tasks, not recognizing items. What is this? It's a watch. What is this? It's a ring. Being able to identify certain name finding difficulties. Those are examples of things. And you'll know the big thing, in corrections, if you have someone that has dementia and they start wandering, or they start looking in other people's possessions or property, what's the problem with that? Well, they're likely to get beat up or killed, right? it's a public safety issue. So you really need to make sure, and y'all know this, that one of the things we see, a good thing for that matter, is some of our inmates actually will step up and help out the older inmates that are struggling or might be demonstrating some dementia, and they'll help them get to the chow hall or help them, get around or navigate prisons. But the problem is, at what point do you really need to think about having them maybe housed in a different living situation as opposed to general population? They need more time to eat, they need more time to ambulate, point A to point B, and that sort of thing. So the big thing is you want to be able to recognize dementia. We have a manuscript under review right now that we're going to hopefully publish soon, but we're looking at this. And I think the whole thing of frontotemporal dementia, we see these 70 and 80-year-old men mainly that have no criminal history at all. And then all of a sudden one day they shoot their wife with a shotgun and kill her. And then now they're in prison. So I think we're going to see that in the next 10 or 15 years, a growth in our dementia folks that are coming in behind bars. So just a point, y'all probably have heard of sundowning or sundown, that this is common. It typically occurs in limited stimulation like ICUs. Y'all know that some of our housing facilities, some cells, and I'm not getting political here, may not have optimal lighting. Like if they don't have a window or they don't have a way to, day, night, diurnal variation and that sort of thing. So that is an important thing. And some of our inmate patients can sundown. So this is not in any way encyclopedic. I'm probably missing 10 or 15 different dementias, but I put some of the more common ones. I would say Lewy body dementia is a new one that's kind of come out. I'd draw y'all's attention to that. Vascular dementia, also referred to as Binswanger's if it's more subcortical and that sort of thing. But we see a lot in our system, and I don't know if y'all see this too, but we see a lot of substance-induced persisting dementia, like alcoholics, patients with alcohol dependence, or other people that do a lot of inhalants. They can basically fry their brain, and then they have a persistent dementia. And we'll talk about head injuries in a second. So again, I'm a visual person. This just shows different stages of Alzheimer's disease, healthy versus preclinical to mild, moderate, to severe. And here's some other dementias. And in DSM, they have it where you have these different dementias that's a clear etiology, but they want you to specify, could it be due to AIDS or HIV? Fortunately, we've come a long way. We don't see a lot of that, but Parkinson's, very common. Huntington's, you may see some patients. We have a couple in Texas, Huntington's, Parkinson's, head injury, Niemann-Pick's disease, Creutzfeldt-Jakob, again, very odd diseases, prions and that sort of thing. But I would say that probably the most big ones you're going to see the vascular and head injuries and that sort of thing. So here's another important take-home point is you can have both. You can have, and I love with medical students and residents, they think, oh, you can only have one. No, you can have both. You can have a patient has dementia, and y'all know this, they develop a UTI, and then they get really goofy and they kind of lose it, or let's say they have fluid in their lung, they have pneumonia or what have you. All it takes is just a little bit of infection, a little bit of imbalance, a white blood shift, and boom, they show delirium. So you can have dementia with superimposed delirium. And then I would say a good pearl is assume delirium until proven otherwise. So don't just immediately chalk up, it's just dementia, give him a posy, put him back in his chair. No, you got to think about dementia too. Point of the slide is, I know a lot of people just think it's only males, but no, it can be females too. So that's really important. And we have a developmentally disabled program in Texas, one for male and one for females. And it's kind of sad. We have about 600 males and about 100 females, but we have picked up some females that don't have a developmental disability. They more have dementia. And now they're in a developmental disabilities program. So that's probably not the best place for them to be. So we're working on getting them into where they have infirmary level of care, where they can have more assistance with their feeding and hygiene and ADLs, activities of daily living and that sort of thing. So let me just move on in the interest of time. Y'all know this stuff, that there's a lot of medical conditions that can cause I talked about it earlier. All it takes is a little bit of the electrolytes being off, or if your thyroid's off, your parathyroid's off, what have you, infection, substance induced. But I want to draw your attention now that all it takes, and y'all know this, if we did a study, how many of our inmates have had a head injury, a closed head injury? Yeah, probably 95% of them. They probably have all gotten hit in the head with a 2x4, been in a wreck or what have you. So it's really hard. It's a very non-specific issue, but I want y'all to be aware of that you can have a contra coup injury where it's not just the frontal, but it's the rebound. And if you think about the brain kind of having the consistency, not in gross anatomy where it's kind of hardened and, formaldehyde baked sort of thing, but it was more, it's very gelatinous. So think about kind of like the brain being more like Jello, akin to Jello. And all it takes is that shearing the back and forth. And we'll talk about that. But typically the most commonly affected are the frontotemporal regions. And I talked a little bit about the coup and contra coup, the blow and the counter blow. And here's a really good example of that. So you kind of have this axonal shearing with a direct head injury and the back. And I'm a huge hockey fan. And so it's kind of sad to see this when you see it with competitive hockey players, football players, other sports. I think there's more and more attention to the, chronic traumatic encephalopathy sort of stuff. But let me draw y'all's attention and let's ask, we'll have some audience interaction here and no one can cheat if you already know this. So who is this dapper young man wearing a very fancy outfit from a while back? Kind of looks like Christopher Reeve, right? From a long time ago. Well, this is Phineas Gage, and he's holding a tamping rod. And I don't know anything about railroads, but he's holding a tamping rod. And if you notice, he has a little bit of a ptosis of his left eye. So his eyelid is drooped, right? And he may have a little bit of a facial droop also. I can't see that from that picture from the resolution. But basically, Phineas Gage was working on the railroad all day long, and life was good for him. He was a very well-respected man in his community. And then he was tamping, and again, I don't know how that works, but he was doing something with gunpowder and knocking down that on the railroad track. And somehow the rod got a projectile and basically shot into his frontotemporal region. And the interesting thing, he survived that, but he's kind of like one of the biggest cases. If you ever go to a neuropsychiatry conference or anybody that does neurology and psychiatry with frontal lobe syndrome, he's kind of the poster child because he changed from being a very religious, prim and proper, upstanding, law-abiding individual to burping, farting, hypersexual, grabbing people, in their genitals. And so he had a huge personality change. And so the point is that you can see this with frontotemporal injuries where people change. Now, some people become just very kind of apathetic, kind of like they're stoned out of their mind and they're just lay around and they don't do anything. But then you have other people that really become, so I have it here, apathy and then versus disinhibition, being overly jocular, having personality changes. So I wanted just to draw y'all's attention to that. If you have someone that comes in as over familiar, in your face, in your grill, being very inappropriate, obviously you need to think about mental health. Maybe they're bipolar, maybe they're manic or hypomanic or what have you, or maybe they're under the influence of something, but you also want to think about kind of head injuries and frontotemporal things. So let me just move on in the interest of time. I think y'all know seizures post-ictal. They can have confusion and acute agitation after a seizure, but it typically wears off. They usually just kind of sleep it off. Parkinson's disease, very common. The medicines we use elevate dopamine. And so the big thing with that is they can misinterpret their environment. They can actually develop psychosis. When I was a resident, we used to work in a med psych unit and we treat a lot of patients with Parkinsonism. And we did ECT, electroconvulsive therapy, because the problem is if you treat the psychosis with an antipsychotic or you lower their Parkinson med, they freeze. So it's a really tough, that's a very tricky disease state to try to manage someone that has Parkinson's. And they intermittently, obviously a lot of them have comorbid depression, comorbid dementia, but they can develop psychosis. So that's an important teaching point. And then I don't have a laundry list of different autoimmune or rheumatologic conditions, but MS, multiple sclerosis, can obviously cause focal lesions and CNS changes. Same thing with, lupus. I think lupus is, the way I learned it, it's the great imitator. So it can present any way. But there's probably others, vasculitis. There's a laundry list of different things that can cause change in personality. Again, HIV, fortunately, we don't see as much encephalopathy as we used to. Again, neurosyphilis is the great imitator. And I read that there's a national shortage of penicillin. So think about syphilis, think about neurosyphilis. So especially in your immunocompromised patients, anemia, hepatic, I think I've already made that point, hypo or hyperthyroidism. And then here's one, I really like this. So I'm sorry if I kind of go off topic here. And I'm going to, again, this is Joseph Penn saying this, not state of Texas, but we in prisons and jails, we've become the mental hospital for the world, for the United States. Can't speak for the world, but so we have patients now that used to be on the back wards of the state hospitals that are now in prison, incarcerated. And so some of the things you see, both whether they're intellectually impaired, like formerly known as mental retardation, developmental disabilities, or schizophrenia, something's wrong with their baroreceptors about water, drinking, and consumption. I get it. Like everyone's like, push water, drink water, push fluids, especially when it's 106 here in Houston today. But the problem is we have some patients that they become water intoxicated. They have psychogenic polydipsia. And I'm just going to throw out here that you have to be very careful with these patients, because the first thing is you really do want to make sure maybe they have some primary malignant tumor. Could they have something that causes their syndrome of inappropriate antidiuretic hormone, SIADH, or something like that? But one big thing is don't try to overcorrect this, because if you go in there, Billy Badass, and you try, pardon me for swearing, sorry, if you go in there and you're over aggressive and you try to correct it, you can cause cerebral edema and central pontine myelinosis. So you don't want to do that, because that's basically the brainstem herniates. Think about it, the skull is hard and you can't, it's not flexible. So the only place the brain has is to expand down through the brainstem, and then they basically, they herniate and they're dead. So don't do that. Obviously type 1 and type 2, if their diabetes is not well controlled, y'all know this. And then thiamine and folate and all those different things from chronic malabsorption, or from alcohol or other intoxication where people don't really eat or drink and get their nutrients that they need. Okay, so I wanted to kind of throw out a couple of things. So what I typically do with students is, with like med students, I say, okay, well, what do you see here? And then they kind of get hung up on the obesity, they get hung up on the tats. Well, what about buffalo hump and stria? So think about things like Cushing's. If you have an overproduction of cortisol, we've seen a couple of cases of that. And the flip side, underproduction like Addison's and that sort of thing. So think about those. Oh, I'm so sorry. I apologize. That's a selfie of me. I did not mean to put that in this presentation. I'm really sorry. I apologize, Mike, profusely. No, kidding aside, the point is, you may see some folks in prison that are all about bodybuilding and getting beefed up. And we know that's adaptive, right? Because the bigger you are, the stronger you are, the less likely you are to get killed or beaten up or extorted. So think about things like anabolic steroids and that sort of thing. So we can talk about that at the end. Let me just close here now. The thing that we do, iatrogenic, that we as healthcare professionals trying to do the best we can, but unfortunately we cause a lot of this stuff. So using Benadryl, using Cogen, using Artane, a lot of the medicines that we use to treat psychiatric issues that cause side effects like the high potency or mid potency antipsychotics, we need to use anticholinergics. And as a result, a lot of the medicines we have anticholinergic effects. And so it can cause confusion, dry mouth, blurry vision, constipation, all those things. It can precipitate narrow angle glaucoma, closure. So those are things to think about. It's amazing. Some patients really get a buzz or high off Benadryl. Go figure. You and I take Benadryl when we're sick, and we don't like the way it makes us feel because we feel kind of like we're in a fog, and we really don't like it. Well, there's some patients that take 50 times what you or I would take, and they love the effect. It gives them a buzz. Y'all probably remember this: mad as a hatter, dry as a bone, red as a beet, mad as a hatter. But that's a really good thing to think about with anticholinergic, how it presents. Again, it's because of the anticholinergic blockade, the dilated pupils, their flushed skin, their dry as a bone, all that. And again, I'm poking fun here, but people say, oh, it can't be his Benadryl. He's only on 50 milligrams of Benadryl and he's only 60. But yeah, yes, it can cause also, I neglected to mention, it can cause acute urinary retention. So yes, the anticholinergic medicines can cause a lot of problems. Not so much recently, but when Depakote and valproate first came out, there was the thing about they could elevate the ammonia and it could cause mental status changes. I've already talked about steroids. Good news with Hep C, we don't have to use interferon as much, but when I first started, we used to have to check people baseline and follow up whenever they were getting interferon treatment for hepatitis C because of the risk of causing depression. And then this is a new slide I just put in. I'm very proud of myself. This is something I think y'all need to think about. And again, part of the problem is, and again, I'm not pointing fingers, but medical might start some meds for chronic pain, like let's say duloxetine. And I get it. In our system, for example, medical can't use opiates. So what do you have? Well, you have duloxetine or tricyclics. Psychiatry or mental health may start prescribing, Prozac, Zoloft, pick your SSRI or SNRI. Those medicines in combination, and then before you know it, they're on trazodone for sleep or buspirone for anxiety. And then before you know it, they start to develop serotonin syndrome. So the sine qua non symptoms are fever, agitation, sweating, shivering. You can actually get clonus. That's a thing you can look for, ankylosing, or muscle rigidity or confusion. So the management's simple: IV hydration, you stop the medications, kind of like a medication holiday, and then you don't do it again. You try to minimize. So in our system, we try to do medication alerts. When someone's on duplicative therapy, like say they're on 2 SSRIs or they're on SSRIs plus a medicine that elevates serotonin levels. So I'd like to really draw y'all's attention to that, to take that home. I should have some psychedelic music now. This is the part of the talk where we talk about ingestions and abuse of various things. Y'all recognize, obviously, OxyContin, Vicodin, Percocets, Percodance, Coke, heroin, acid, shrooms, triple C's, Xanax, Valium, all that fun stuff. The big thing now in our system in Texas, particularly, I'm really curious to hear from others, but K2 and spice are the biggest problems we're dealing. Bath salts, but we have it in Texas where the drones, like prison gangs and free world gangs, are now trafficking and trading and using drones to drop off bath salts, K2, spice, and other things like that. I've heard of Flocka in Florida. There's other things. When I was in Connecticut and Rhode Island, we had a lot of problems with, and I know y'all have probably all done this, but marijuana laced with embalming fluid, formaldehyde. And you can call it wet or illy, but the problem with that is when people smoke it, they don't clear. They get psychotic as all get out. It could be 2 to 3 months before they clear from that. It's kind of the same thing we're seeing with K2 and spice. We don't really know what's in it. We know that a lot of the correspondence to mail can be laced with it because it's a chemical and they smoke it or ingest it. So the point I'm trying to make is, and if you all have ideas, we don't really have a good way for testing for K2 and spice and stuff like that, but you can see a lot of bad outcomes from this. And it can present as psychiatric or psychotic, and they don't clear. It takes a while for them to clear. So unfortunately, our inpatient psychiatry people are really annoyed because they're like, all these people are coming in, tying up our beds, and they're all on K2 and spice. So that's some of the challenges, synthetic cannabinoids. So I think I covered a lot of stuff in a short amount of time, and I'd really like to hear from y'all what questions y'all have, and comments and questions. And if y'all have ever seen some of these really interesting cases or patients, please feel free, but I'm open to questions and answers now.
So I'll jump in if you don't mind, Ed.
Sure.
One of the biggest things is so I've seen horrible cases where a nurse said this guy's just got Alzheimer's and he had delirium and he was septic and he died. And so how do you approach things like custody, thinking everything that's absurd and crazy behaviors in that it's all either mental health or the inmate being a belligerent jerk? And I mean, that's the attitude out there, certainly in the custody world, and it it filters down sometimes to the nursing staff. And I guess my biggest thing would be, how do you get the word out, the education word out, around treat it like delirium, because you're going to be wrong if you think it's dementia all of a sudden. Nursing staff don't always know that.
Yeah, Mike, that's a great point. And I think part of the issue is education. I think our biggest problem in Texas is we have such a high turnover in our nursing staff. We were maybe 10% vacancy shortage before COVID, and we utilized a lot of agency and like float nurses and that sort of thing. But then during COVID, we lost all of them to travel nurses because they were getting tons of money and getting to go all over and earn frequent flyer miles like Dr. Wu, and travel the world and be 1K and all that fun stuff. But I'm poking fun at Dr. Wu. Sorry, Johnny. So the point is, I think at the end of the day, it really boils down to three things. It's nursing, medical, and custody. And I learned this from Dr. Daniel. It's a shared responsibility. And the problem is when there's a death, and you'll know this, guess what happens? Everyone gets sued. Custody, medical, nursing, whether you use MDs, whether you use APRNs, everyone's going to get sued. And then the medical director and their, professional administrative capacity. So I think at the end of the day, it's really doing education, just like what we're doing today, of, hey, think about this, just think about it. And it never hurts to send someone offsite. I get it. It takes time and effort and resources. You have to have 2 to 3 custody staff and the gas. And then there's the escape risk, the public safety issues, the cost of sending someone offsite to a free world. And y'all know this, some emergency rooms do a really good workup and some like do the mega workup and they bilk you and then you have all these bills. So I think that's those are some of the challenges we have as correctional leaders, is doing what's needed for our patients. But I think at the end of the day, it's education, staff education. Think about this. Don't neglect stuff, because all it takes is one patient to go south and you're talking lawsuit. So again, I don't think our decision should be geared by lawsuit avoidance, but we want to do what's right for our patients. Think of it like, if that were your loved one and they're not doing well, wouldn't you want to provide good health care? And so that's how I think it's all about education and good communication. I think nursing, not feeling afraid to call the on-call medical or hey, I really think this patient needs to get brought down. And when custody balks, nursing or medical going to custody leadership. And again, you have to be skillful and you don't want to step on toes, but how to go up the chain and say, hey, captain, hey, can you talk to the lieutenant? Hey, can you talk to the major? Can you talk, to the sheriff, the warden, or whatever? But it's really diplomacy and saying, I really think this patient needs to get brought down. I can't just go and see him cell side. They need to come down to the clinic where we can do a really good workup on him. And if not, we need to send him off site. And I think at the end of the day, I think sheriffs are probably a little more attuned to that, because at the end of the day, it comes out of their budget, right? So anyways, those are my things. Education, collaboration, and communication is what I would throw out.
Quick follow-up question. If they're really out of it, you're going to need to sedate them. And the use of forced psychotropics acutely. Can you comment on that at least briefly? I think I know the answer, and I think we need to get the word out there.
Sure. So what I would say is, try to be very judicious and careful. The problem, if you give someone, you give somebody a high potency, let's say give them Haldol. Okay. If I give Dr. Johnny Wu 5 or 10 milligrams of Haldol, and now he has an acute dystonic reaction, or he has a pistotonus, or he's probably not going to be very happy. Plus 2, they could develop akathisia. And this is a whole separate talk in and of itself about the extrapyramidal side effects of some of the medicines we have, some of the antipsychotics. I would say probably short-acting benzos. And I get it. This is the problem, because if you start giving benzos and then the word gets out, Dr. Perini, he gave me that medicine. It really made me feel really good. I was super chill. I loved it. And then before you know it, you have 20 other people wanting, hey, I want some of that Ativan stuff.
And
so you got to be really
to
correct.
Get it.
You want to be correct. You want to be very careful. So I would say very judicious use of emergency psych meds, and reassessing. I think that's the other thing. What I've seen in some situations, use of force, they give them shots and then they put them in the cell and then no one bothers to go and check up on them again.
No.
And then they don't wake up, or they, if they're prone or it's a restraint, it's a, seclusion, restraint, death. So those are the sort of things to be very careful about.
Yeah, I've seen it where it's all about giving them just enough to get them transported so they can get worked up.
That's fair. I think that's a really good approach.
Mike?
Who's next, Charles?
Yes. One thing that I've come to realize is that correctional officers see the patients, the inmates, 23, 24 hours a day.
Mm-hmm.
Medical people may see them 1 hour every so many days. And that consequently, I think that correctional officers, particularly those that work with patients in the mental health arena, need to be part of the team. There's always the HIPAA concern. Well, we can't tell them this because it's a HIPAA violation. I say, well, correctional officers are sworn to secrecy also. And it's very important that if they see a patient acting in a particular way, that they realize that it may be psychological as opposed to being a bad person, to use your words, Joe, a badass.
Right.
And to treat them with mental health concepts and to notify medical, not just take them and throw them in, say. So the correctional officers are a vital part of the team, particularly with mental health.
Charles, I couldn't agree with you more. I think I've come to really respect correctional officers. Obviously, there's some that are less good than others, but when you find there's some that are, I just think they're all about pride and professionalism and doing the right thing. And, I look at it from do you want your staff getting injured or assaulted, or do you want to do the right thing? And so at the end of the day, it's all about collaboration and relationships and developing that trust, to use a term, like a trust-based relationship, that they have your back. But no, I couldn't agree with you more, Charles. I think you're spot on. It really is. And to borrow again, Dr. Earlier, it's a shared collaborative. Dr. Daniel, thank you. It's a shared collaborative responsibility. We got to do this together, because if there's a bad outcome, everyone's going to be held accountable. Michelle, did you want to go next?
Yeah, that's great. Thank you, Joe. A great presentation. On your first case, I believe it was the first case, you mentioned, you gave the scenario and you posed the question of what would you do if you had no labs or x-ray, but you didn't really say exactly what scenario. And so I was curious what you would do. With our facilities, we're limited on both. And so what would you do? I know you mentioned the urine dip, quick and easy one, but any other tidbits for those of us in limited resource locations?
Well, Michelle, I'm so glad you brought this up. We actually have this issue right now. We have a young man who's probably developing first break psychosis, probably schizophrenia, and he has refused everything today, everything. And we're working on trying to transfer him to the state hospital. And it's kind of one of these, we're probably going to have him go straight to an emergency room. But what if he refuses? And that's the problem. You can get somebody from point A to point B. When they show up in the ER, what if they refuse everything? And so then it's kind of like, it's very much subjective up to the ER doc of, hey, are we going to do hands-on? What are we going to do? So I think that's really the trick, is all about collaboration, coordination. And I would say, I don't have a magic formula. I think, we as medical leadership or mental health leadership, we need to be the ones that kind of drive what should be as a disease management guideline, what would be a good workup. What we did, for example, I know some of y'all have been to our facilities in Texas. Recently, we partnered with an emergency room group, and I'm very pleased to report we have it to where there's like, we can send people from 6 or 7 different prisons that are near Huntsville, Texas, the epicenter of Texas. We can send them to a local, they're still in a maximum security prison, but they actually have ER docs that are staffed there, and they can do workups. They have the labs that they need to do. So I think you may need to look at point of care testing. You may need to look at telemedicine. I think vitals are really important. But, again, Michelle, I don't think there's any magic, do this or don't do that. I think you get what you can and you use your clinical judgment. And I get it. I see this happen all the time in lawsuits where people are like, well, why didn't you do this? And you get somebody, and no disrespect, you get somebody from New York City or Boston where psychiatrists are tripping over each other, or other medical people are tripping over each other. And they're saying, well, you didn't do this, you didn't do that. And it's like, well, yeah, we're in Gatesville, Texas, which is, we have a Walmart there and that's about it. So those are some of the real world issues we struggle.
Yeah, it's absolutely a challenge because we will pretty much send everybody out because we don't have the resources. The problem is, like you mentioned earlier, when you send them out, what will they do, if anything?
Right.
Getting the information when they return that you're really no better off than when you sent them.
Yeah, I was just going to make the point. One thing I found really useful, especially during COVID, is to have multidisciplinary treatment team meetings. So you can do it Zoom, you can do it Teams, or however, but I think, or even a conference call, the more having nursing, medical, mental health, custody, operations, all on one call, and you get some of the greatest information, not necessarily from the MDs and the PhDs and the DOs, you get some of the best stuff from the case manager or the correctional officer. That's the kind of stuff that I think is a goal. So I really think whenever we have a really challenging, complicated patient, and we didn't talk about this earlier, but the whole issue, and I'm going to put on my forensic psychiatry hat, of capacity. Remember, it's not competency, because competency is task specific. Competency is like, are you competent to stand trial? Are you competent to execute a will? Are you competent to get married or whatever, or open a business? That's very different from capacity, which is your ability to rationally manipulate the risks, benefits, and alternatives of a diagnostic procedure or surgery or some life sustaining intervention. So capacity, this is a big thing that comes up all the time with these kind of patients, especially patients with dementia or someone who has intellectual impairments. That's one of the biggest challenges is, and I would say that's where you really do want to pull in psychiatry and mental health, because you want to make sure, is it psychosis? Is it they're just making bad decisions? Or could they have some capacity issue? And then you want to get into the issue of, do you want a surrogate decision maker? Do you want a judge to come in and rule? Do you want the lawyers involved? So that's a whole separate decision making. But anyway, that's a separate talk in and of itself. And I want to thank y'all for your time and attention. And y'all have been awesome. So thank you.
Thank you. Great job. Mike, you're on mute.
I just want to thank you, Joseph. I do want to draw attention to the fact that Steve Shelton is in the room. I'm so pleased. And,
awesome.
And hey, Steve. And,
Steve's awesome.
He says that emergency psychotropic medications only for clear and present danger to self or others, and no alternative exists. I agree with that in principle, but I've also seen cases where if that guy had just gotten a shot of a short-acting benzo and a transport to an emergency room, he wouldn't have died in the institution of sepsis. And it's always so gray. It's hard to make that call, I think, but especially when you've got an out of control inmate.
Yeah.
I know we're a little bit over time, but Dr. Penn mentioned about monitoring and vital signs. I do think that's very vital. A lot of times we don't take the effort to continue to monitor them more closely. And with technology out there now, there's actually less invasive, contactless types of ways of monitoring folks. I was visiting a jail in Kentucky where they actually implemented using radar technology to monitor their patients coming in from off the streets, detoxing, and
really,
ever since they put these units in their cells, they haven't had any send-outs for the past 3 months, and they actually detected someone with developing AFib as a result of that as well. So I think we need to also look at closely monitoring with all the new technologies out there that's contactless.
Right, I agree, totally agree.
Steve Sheldon, I'm going to throw in a comment. giving emergency meds for a medical crisis has actually a much lower legal bar than giving psychotropic meds for what you call and deem a psychiatric crisis and intervention. So helping a patient survive to get to the emergency room for a workup might be a med, but I would not call it an emergency psychotropic med. Documentation is very poor for that. You might say,
Right.
we need to transport this person and we're trying to get him comfortable with transport.
Right.
I think there are ways to do this. And I really like Dr. Wu's comment about considering the new types of health monitoring that are available without necessarily dragging the nurse into the same room as the patient when you've determined you need to do some long-term monitoring and he's not really being a very cooperative person. There's a lot out there that we can make advantage of if we do that. And I would, if I were still doing this as medical director, I'd make the argument that buying this expensive equipment could save a ton of money in transports. And
Right. Right.
One
I agree.
death, the cost of the litigation and settlement of a death pays for the technology.
Oh, easy. Great point, Johnny. Yeah, and Steve, I totally agree with you. The youth, I'm trying not to violate HIPAA and get in trouble, but like he's facing a 5-hour drive from point A to point B. So yeah, I mean, a little bit of Benadryl, a little Ativan might help just make it more comfortable. If you've ever had an MRI and you have to sit there and be still and go into the machine, all of us, we would love a little something, a little Valium, whatever. So yeah, but I think the key is don't overdo it. Because then it's hard to assess. They show up at the ER and they're obtunded or they're not arousable. Then the ER is like, now what do we do? So I think the key is, small doses and reassess. And I'm certainly not advocating for PRNs or anything like that. But I think, Steve, your point is spot on. It's not really an emergency psychotropic med. It's more medical to help with the transport, to reduce shoulder dislocation or fractures or injuries, both to the patient or to staff, because they could hurt them or hurt someone else. So no, you're spot on, Steve. I totally agree.
So
Yes,
we're going
one
over, but
comment.
Jeff, good.
Hello, everyone. Nice to see you. Just one comment about HIPAA. HIPAA has an exception for corrections. And if you need to tell correction officers about a medical or mental health condition, that's covered by HIPAA. And HIPAA is probably the most misunderstood law among not just medical professionals, but everybody.
Great point, Jeff. Thank you. Good to see you, Jeff.
Yeah, nice to
Likewise.
see you. This is great. Even though we've gone over, I don't feel like I could be spending my time any better than I am right now. So thanks to everyone.